So we've already gone through the kidneys. We've talked about nephrons, kind of the structure of a nephron. What does it look like? Where do we find it in the kidneys? And then we've been going through the 3 parts of renal physiology. So does anyone remember the first part? What is that called? Starts with a G. Glomerular filtration, right? So this is where you have that big ball of capillaries. We talked all about that, how the blood coming in comes in a little faster than we're draining it, so the pressure is really high. It's going to force tons of stuff out into the Bowman's capsule, right? It's going to force out tons of water. It's going to force out a lot of ions and nutrients, all kinds of things that are small, but nothing big. No cells, no big proteins. None of those should be forced out, okay? But you pull out waste, but also a lot of good stuff. So remember, just in that first process, we produce like 180 liters of filtrate, a ton. You don't urinate out that much. And so the second step, which we kind of ended talking about, is called tubular reabsorption. And tubular reabsorption happens throughout the proximal convoluted tubule, the descending limb, the ascending limb, the distal convoluted tubule, and the collecting duct. And the role of tubular reabsorption is let's reabsorb most of the water we pulled out. Let's reabsorb all the good stuff, like all the glucose, all the amino acids, all the stuff that we need to put back in our bloodstream. We're going to reabsorb that. Now we talked about how tubular reabsorption in the proximal convoluted tubule, this is where we do a lot of water, a lot of glucose, lots of ions. On the descending limb, we can only reabsorb water. On the ascending limb, we can only reabsorb solutes, things like sodium and chloride ions. By the time we get here to the distal convoluted tubule and the collecting duct, it's hormonally regulated. So it's based on what your body needs, what hormones you're releasing, right? So we talked about a couple of hormones, things like aldosterone and the antidiuretic hormone. Those work here. They work on the distal convoluted tubule and the collecting duct. If, for example, your blood pressure is low, your body is going to put more water back in your bloodstream to raise your blood pressure back up. So these are hormonally regulated towards the end of that nephron. The very last step, the third step in renal physiology, is tubular secretion. This is your body's second chance to get rid of any waste that you might not have gotten rid of during glomerular filtration in that very first step. Or it could be waste that you accidentally reabsorbed in the second step. Okay, so we have a second pass, second chance to clean the blood, get rid of substances. Almost all tubular secretion takes place in the proximal convoluted tubule. So it's happening pretty early. Things you might pull out might be like ammonium, right? We don't need this, we can get rid of this. Other things might be ions. If you have excess potassium ions, you'll get rid of those. Other things like hydrogen. One big thing, and I mentioned that we're not going to cover chapter 26 in here. However, chapter 26 is really important. It goes over acid-base balance. If you look right here during tubular secretion, again, this is your chance to pull out things you don't need. One more time. Hydrogen is indicative of an acid. So this is something that we can pull out, put in our urine, and help to balance our acid-base balance in our bloodstream. Okay, so this is something that can be very beneficial. Other things like creatinine, organic acids and bases, we can pull all those out. We have a second chance to get rid of them, urinate them out of the body. During tubular secretion, this is also a chance for us to get rid of things that might be bound to the plasma proteins, like drugs, for example. It also helps us get rid of things we don't need that end up getting reabsorbed in that second step. So things like urea and uric acid. These make up a huge portion of your urine. They're wastes. But what ends up happening is you pull them out in the first step in glomerular filtration. You put them back in your bloodstream during tubular reabsorption. So in the third step, we're going to put them back in the urine. We got to get rid of those. It's a waste. We don't want it in our blood. Gets rid of excess potassium, and it also, like I mentioned, it maintains that acid-base balance because it can regulate the amount of hydrogen ions that we have in our body. and even bicarbonate ions as well. So again, if we look at this picture, we truly are looking at a nephron, just sort of an artist's rendering of a nephron. I'm going to draw a line right here, because remember, this is separating the cortex up here from the medulla down here. And we're going to touch on this and come back to this in a little bit. So again, first step, glomerular filtration happens in the glomerulus. The second step, tubular reabsorption, pretty much happens throughout the rest of the nephron. Okay, this is putting good stuff back in. By the time we get here, it's hormonally regulated. And the third step, tubular secretion, our second chance to get rid of waste, is happening here. So it's happening right past that Bowman's capsule. Okay. Now, our kidneys do have the ability to regulate the volume of urine that you're producing. They also can regulate the osmolality, the concentration of the solute in your body fluids. And they do this through a mechanism that we're going to walk through called the countercurrent mechanism. Okay, so the countercurrent mechanism basically gets its name because fluid is flowing in opposite directions, right? That's what countercurrent means. Can you think of a place in the nephron where fluid is flowing in opposite directions? If we go back to this picture, where would fluid be flowing in two different directions? It's coming down the nephron loop, and then it's going up the nephron loop. Right next to each other, you've got fluid flowing in two very different directions. Next to this, you also have blood vessels. And the blood supply is flowing in opposite directions. So this is why we call it the countercurrent mechanism. So that's where we're going to be talking about this. Now the countercurrent mechanism, we call it a mechanism because it's actually two parts. One part is called the countercurrent multiplier. This one is focused on filtrate flow in the nephron loop. So this is really looking at urine. The second part of the mechanism is something called the countercurrent exchanger. This is looking at the blood flow in the blood vessels. Now the blood vessel that surrounds that nephron loop is called the Vasarecta. Okay, and we talked about this on Tuesday. So the countercurrent mechanism is made up of the nephron loop, we call that the loop of Henle, and also the Vasarecta that surrounds it. Okay, again, because the fluid is flowing in two different directions in both of those. So the whole role of the nephron loop and the whole role of the Vasarecta is twofold. One, it helps to maintain an osmotic gradient in the medulla, and that's super important. We're going to talk about why. The other one is that it helps your kidneys vary your urine concentration based on what your body needs. If you are dehydrated and you haven't had enough to drink, you're going to urinate out very little urine, and it's going to be very concentrated. If you're nice and hydrated, you've been drinking water all day, you're going to have a large volume of urine, and it's going to be very dilute. So this is just a good image because it's showing you that countercurrent mechanism, two parts to it. Okay, so again, we have the multiplier, which is the loop of Henle. Okay, that's our countercurrent multiplier. We're looking at the urine flow. But we also have this countercurrent exchanger. I'll do that one in a different color. This one's looking at the blood flow through the Vasarecta. And this one flows here. No, I did that wrong. Sorry. This way and this way. Okay. So we've got blood flowing in opposite directions. So this is just trying to show you the nephron loops, and you're seeing how it's flowing in one direction and then it turns, it has that hairpin turn, it flows in the other direction. One thing that we've already talked about is, remember when we look at that loop of Henle, remember when it's coming down, the only thing we can reabsorb is water. When it's going back up, the only thing we can reabsorb is sodium. Okay, so we're going to talk about first this countercurrent multiplier. So again, that is the urine flowing through that loop of Henle. So on the descending limb, I told you the only thing that can come out is water. So it's freely permeable to water. So water is going to pass out of the descending limb into the medulla. So you can see in this picture, I'm going to just draw a line here. Okay, everything above that line is the cortex. Everything below that line is the medulla. So one thing I want to point out on the medulla, if you look down in here, the medulla of the kidney, I like to say it's salty. So the osmolarity of the medulla increases as you get deeper down into the medulla. So it starts up here at about 300 milliosmoles. And as you move your way down into the medulla, it gets down to 1200 milliosmoles. So again, I always, in my mind, I think of it as it's salty. As you dip down into the medulla, it gets really salty, okay? So think about that when you think about this nephron loop coming down. We're able to pull out water. If you know anything about osmosis, the movement of water, water follows salt, right? Water follows solute. So as this limb dips down into the medulla, what's going to happen is it's getting saltier out here. So you're going to pull out some water up here, but as you get deeper down, you're going to keep pulling out water because water inside this tube is following salt. It's coming out because this is very salty out here. So what essentially you're doing is you are concentrating that urine down. And you can see that. So the urine goes from 300 milliosmoles to 400 to 600 to 900 to 1200. Notice what it's doing. It's matching the osmolarity of what's up here. Let's think about osmosis. It is the movement of water until what happens? Until you reach what? Equilibrium. Okay, so water's going to move until the osmolarity is exactly the same. So by having this medulla be really salty, that is allowing us to pull out all this water, and we're going to be able to concentrate that urine down to 1200 milliosmoles. We've pulled a ton of water out. Remember we talked about how up here in glomerular filtration, you pull out 180 liters of fluid a day. That's huge. This is a ton of water. We got to put it all back into our bloodstream, and this is where it's doing it, right, on the way down. Now on the way back up, are you able to get water out of that nephron loop on the way back up? Nope. What can you pass out of that loop on the way up? Only solute, right? So on the way back up, it's impermeable to water, but it is selectively permeable to solutes, specifically sodium and chloride. What are sodium and chloride if we put them together? Salt, right? Think about this. If we take all this water out of the tube and put it into the medulla, what are we doing to the medulla? We're diluting it down, right? So on the way back up, as this urine flows up, can't take out any more water, but now we can move salt back out. And we're going to make this medulla more salty, right? And so we can move out the salt from inside of that tube. Oops. So it's selectively permeable to sodium and chloride, and it's going to cause the osmolality to decrease to about 100 milliosmoles. Okay, so if we look at this picture, okay, we're going to move solute at this point. Okay, so the solute is going to just move out of that tube, and it's going to cause that fluid inside to drop to about 100 milliosmoles. So we actually make it way less concentrated. We've got the salt out now. So this is how we're able to move water and ions like sodium and chloride back out. We don't pee all that out. We don't need to. The countercurrent exchanger is the Vasarecta. That's what's happening in the blood vessel that surrounds that nephron loop. And so the function of the Vasarecta is to help maintain the gradient in the medulla, keep it nice and salty, and it's going to pull up all that water that was put in and the solutes and put it back in your bloodstream. Okay? The volume of blood at the end of the Vasarecta is always greater than what it started with. That should make sense because you're reabsorbing all that water in that solute. So if we go back to this picture, this makes it look like this water and this salt are just going into the medulla. And initially they are. They're going into the medulla, but then very quickly they're picked back up by the Vasarecta. Because we don't just put this in the kidney, we put it back in the bloodstream. That's tubular reabsorption. Put it back in the bloodstream. Okay? And so that's the Vasarecta. That's the countercurrent exchanger. So this is showing, you can see the blood coming down, and you can see that as the blood moves down, again, remember, we're moving down this really concentrated medulla, so we're going to concentrate that blood. Remember, water follows solute, so we're going to move that water where it needs to go. We're going to concentrate that blood down, and then on the way back up, it's going to match the medulla as well. Okay, so we're going to pull the water and the solutes and put them back in the bloodstream. So this gradient is super important because it actually helps to raise your urine concentration when you're dehydrated. So why do we have this gradient in the medulla, and why it's there is to help concentrate the urine down. So this is one that you already know. You know, we've talked about when you're dehydrated, if you haven't had enough to drink, the amount of urine you produce is really small and it's really concentrated. Whereas when you're overhydrated, you produce a lot of urine and it's really dilute. This has a lot to do with hormones being released. When you are overhydrated, you do not release a lot of the antidiuretic hormone. Think about that hormone again, antidiuretic. A diuretic makes you pee, an antidiuretic makes you not pee. So when you are overhydrated, you don't need to produce this hormone. The only time you produce this hormone is when you're dehydrated. You make a huge amount of this antidiuretic hormone because the last thing you want to do is pee. It makes you not pee. It makes you save that water. And so typically what's going to happen, I'm going to show you this in a picture. Okay, so we're going to look over here on the left first when you're overhydrated. So this is when you've been drinking water all day long. So we can see the urine coming into the nephron loop. Again, on the way down, we can pull water out. So we're going to pull out the water. We're going to concentrate that urine down to 1,200 milliosmoles, right? We pull water out because we're going into that salty medulla. We pull that water out. On the way back up, we can't move water, but we can move salt, right? So we're going to pull the salt out on the way back up. And we're going to get this urine to about 100 milliosmoles. That's pretty dilute urine, okay? It's then going to just pass through this collecting duct, go into the minor calyx, the major calyx, through the renal pelvis, through the ureters, into the bladder, and out the body, okay? That's when you're overhydrated. You're getting a lot of urine. It's really dilute, very clear. Over here on the right-hand side, this is when you're dehydrated. You haven't had enough to drink. Or maybe you only had like a cup of coffee, which has caffeine in it, which also dehydrates you. Same thing at the beginning. Urine comes in, moves down that tube. Okay, we're pulling out our water. We're going to concentrate the urine to 1,200 milliosmoles. As it moves back up, we pull out the salt, get it to 100. That's exactly the same on both sides. Whether you're dehydrated or overhydrated, it looks the same. But remember when we talked about that second step, tubular reabsorption? I told you that by the time you get to the end in the collecting duct, we're using hormones. And so let's look at what happens when we use these hormones. So when we're dehydrated, we release the antidiuretic hormone, which makes you not pee. What the antidiuretic hormone does is it acts on the distal convoluted tubule in the collecting duct, and it causes you to open something called aquaporins. Think of that term, aquaporin. They are literally water holes. So you open up these little water holes, okay, in the distal convoluted tubule and the collecting duct. So as that urine moves down the distal, as it moves down the collecting duct, remember it's still moving down that medulla. The medulla is salty. If you now have all these water channels open and water is able to move, water follows salt. So as this moves down the medulla, if you've got water channels open, you're going to be moving water out. What's going to happen is you're going to put water out of the urine. You're going to take it out of the urine, and you can see that urine's going to get more and more and more concentrated. And what you urinate out when you're dehydrated is 1,200 milliosmoles, versus when you're overhydrated, it's only 100 milliosmoles. Okay, so there's a huge difference between when you are overhydrated versus when you are dehydrated. Okay? And that has to do with not only the hormones being released, but it also has to do with how salty that medulla is. So one other thing I want to mention is some diuretics. So remember, I told you a diuretic makes you urinate. This is anything that's going to enhance urinary output. So anything that inhibits the antidiuretic hormone. So let me go back. The antidiuretic hormone causes you to open these channels. You pull water out of your urine gets more concentrated. Okay? If you take a diuretic makes you pee more. There are some diuretics that actually inhibit the antidiuretic hormone. If that antidiuretic hormone can't work and open these channels, then it's going to look like this. And you're going to urinate out a lot of water, and it's going to be very dilute urine. Okay? Alcohol is an example of something that inhibits the antidiuretic hormone. I remember my roommate in college, she would always say, don't break the seal. I don't know if that's a thing anymore. That was like 20 years ago. But she would say, don't break the seal. So if you go to a house party and you're drinking, she would go, oh, don't pee, because once you pee, you're going to have to keep peeing. And that happens when you drink alcohol. You know, when you drink alcohol, a lot of times you'll urinate a lot when you're drinking alcohol. And then if you drink too much, the next morning you wake up, you have a headache. Your mouth feels like you've been chewing on cotton. Your mouth's really dry. The reason is you are severely dehydrated. Because when you drink alcohol, this can't happen. So even when you are dehydrated, alcohol is preventing this from happening. It is preventing you from putting the water back in your bloodstream. You're just peeing it out. So you get more dehydrated. So when you drink alcohol, you get super dehydrated. You go to bed, you sleep, you wake up the next morning. This is why you have a headache. Because you're dehydrated, your blood volume's low, your blood pressure's low, you got a screaming headache. This is also why your mouth is really dry. It tastes like you've been chewing on cotton because you're super dehydrated. So, you know, typically the rule of thumb is for every 8 ounces of alcohol that you consume, you need to chase that with 16 ounces of water to keep yourself hydrated. Okay, that's a lot. So alcohol is an antidiuretic hormone inhibitor. We also have sodium reabsorption inhibitors. Remember, water follows salt. So if you are unable to reabsorb sodium, that also means you are unable to reabsorb water, which means it comes out in the urine, right? Water follows salt. If you pee out salt, you pee out water, okay? So examples of this are things like caffeine. I remember when I was at Ohio State, I took a lot of chemistry classes. And one semester I was taking organic chemistry, and my organic chemistry lecture started at 7 a.m. Ohio State's a huge campus. There's no driving on campus. So I lived in the honors dorm, and I just had to walk all the way across campus. And I would get there, and there was a coffee shop next door. I do not like coffee. But I would go get coffee and sit in that lecture. The reason is that as I would drink the coffee, I would have to pee, and it would keep me awake, thinking about the fact that I had to pee. So caffeine is something that causes you to have to go to the bathroom, right? Drugs for hypertension. When someone has high blood pressure, they have high blood volume. They have too much water in their blood, right? So drugs for hypertension cause you, a lot of times, to pee out extra sodium. Water follows salt, so you're also going to pee out extra water. That's going to bring your blood volume down. It's going to bring your blood pressure down. Right? So those go hand in hand. Same thing with edema or swelling. A lot of times these drugs prevent sodium reabsorption. If you pee it out, you pee out water. It helps to reduce the swelling, helps to reduce blood pressure. Loop diuretics. These are a little different. Loop diuretics are a type of drug that actually prevents you from getting the medulla in the kidney to be so salty. And if the medulla is not salty, then you can't concentrate your urine down to this. You can't get it down to 1200 milliosmoles. If, let's say that the medulla only gets to 600 milliosmoles, well, that would be as concentrated as your urine could get. So a loop diuretic actually interferes with how salty the medulla in the kidney is, and that's going to influence how concentrated your urine can get. And then we also have osmotic diuretics. An osmotic diuretic is any solute that remains in your urine is going to pull water with it. So I like to say water follows salt, but another way to say it, which is probably better, is water follows solute. So if you pee out salt, you're going to pee out more water. But if you pee out solute, like glucose, you're going to pee out more water. Okay, this is why people who are have hyperglycemia, people have high blood sugar, they pee out the extra sugar, they're going to pee out more water. So they urinate very frequently. Okay. So one of the things, I'm going to turn this on, my document camera. I'm going to put our lab under here. Because when y'all did the kidney lab, we kind of skipped over one of the physiology experiments. So if y'all have your lab manual, you may want to open that. To page, let me find it. Just to the very first page, page 77. So this was a physiology experiment that kind of walks you through how the medulla of the kidney works to concentrate your urine down. We skipped it because we hadn't really talked about it. We hadn't really talked at all about the kidney. So it wouldn't make sense to you to do it when we did this in lab. So now that we've kind of talked about the kidney, we talked about the salty medulla is able to pull water out of your urine and concentrate your urine down. I'm just going to walk you through this as if you had done the experiment. Okay, so I have it on demo over here. So I'm just going to go over what we do in this experiment. So in this experiment, this is looking at the medulla and how it works to concentrate your urine. So it says at the beginning here, step number 2, well, put your goggles on. And then step number 2, it says get some dialysis tubing. Dialysis tubing looks like this. Okay, it's just clear tubing. I'll cut it so I can show you. I think I'll work with this in 103, right? Did you all remember this in 103? You take a piece of tubing, and I just cut it, so now it's open on both ends. And so you just tie a knot in one end. And once you have a knot in there, you have to get this wet so you can open it. So I just stick it under the water. Get it a little wet. And once it's wet, you can use your fingers to kind of, I'm going to say I can open this, but this stuff's really tricky. Do y'all remember this? Remember using this? And I can't see. The older I get, I start holding things way far away from my face. My husband has to hold the menu at the restaurant for me. Yeah. Alright, so I got this open. I know you can't see it, but I did get it open. And then what you do is you put some fluid in this tube. So I don't have any over here. I've already got these on demo. But you use a little dropper and you add fluid to this tube. And then you tie a knot at the end. Okay? And the fluid that is in this tube is basically just water. You're just going to add water to the tube. Tie a knot at the end so it's filled with water. So I'll show you what that looks like. Okay, so here's an example. Okay, so you can see this is just has water in it. I've got it in the tube. There's a knot at both ends. Okay, pretty simple. Then what you do is you make 2 of those. Okay, so you make 2. Then what you do is you dip, I have 2 beakers over here. You put one of them in this solution, which is basically just water. So you put a tube filled with water into a beaker filled with water. Okay? And we call this the cortex of the kidney. Is water going to move in any direction here? Is there any part where there's more water? Like, is there more water in this beaker than what's in the tube? No. The concentration of water is exactly the same. Okay? The other tube we put in this beaker, and this one should look a little different. I can see it from the top down. This tube I put in this beaker, and this beaker is filled with salt water. Where would you find more water? Fresh water or salt water? Fresh water. Salt water has a lot of solute in it, so it has less water. Okay? Think about osmosis. Water goes from a what to a what concentration? High to low. And where do you have more water? in this tube, right? So water is actually going to leave this tube and go into the beaker. So this dialysis tubing is permeable to water. It lets water move back and forth. So in this case, if you take fresh water in this tube and you dump the tube in salty water, water's going to follow salt. It's going to go from inside the tube to inside the beaker. So what's going to happen to the weight of that tube? It should drop, right? If you're losing water out of the tube, the weight of the tube should go down. So, I'll pull these off here. All right, so this is sort of mimicking the medulla in the kidney. So remember I told you that the medulla is salty, and it's salty for a reason. Because as that nephron loop and the collecting duct move down the medulla, water is going to follow that salt. It's going to get pulled out of your urine. So what we can see here, we can use these numbers. These aren't the same numbers that I had, but one of those bags, remember I told you I put water in it, and I put it into the cortex, which was a beaker of water. There's no salt in there, so water's not going to move in any direction. The beginning weight, oh, y'all can't see that. Let me write it with a pen so y'all can see better. The beginning weight was 26.2 grams. Did that one lose weight? No. If I put a bag of water in water? No. So the end weight was 26.2 grams, and the change in weight was 0. Okay? That mimics the cortex. Bag number 2 was plain old water, but this time we put it in the medulla beaker, the beaker with all the salt water. This one started at 25.3 grams. I tried to get them as equal as I could. And remember, water follows salt. So water left the bag to go into that salty beaker. And the end weight after about an hour was 23.6 grams. It lost 1.7 grams, right? So the point of this experiment was just to show you how the medulla is working, right? Just to show you water follows salt, right? To give you an experiment where you could look at osmosis. So this part says, what part of the nephron is represented by the dialysis bag? So that could be the collecting duct, or the distal convoluted tubule, or the loop of Henle, or the proximal convoluted tubule. So any part of the nephron tube could be represented by that dialysis bag, right? Proximal convoluted tubule, loop of Henle, distal convoluted tubule, or collecting duct, okay? Then it asks you, the low osmolarity solution is most similar to which region of the kidney? The cortex, right? You put it in the beaker of water, well, that's trying to simulate the cortex. And it even tells you up here. The high osmolarity solution is most similar to which region of the kidney? The medulla, the salty part. Which bag gave up the most water? The one that was in the medulla, right? The salty water. And then it says, briefly explain the results of this experiment. So you do that on your own. So remember, this has to do with how we reabsorb water out of the kidneys, right? Does that make sense? Does that experiment make sense? Would not have made sense had you done it before we talked about kidney physiology. Okay. So we have done all 3 parts of renal physiology, right? We did glomerular filtration, tubular reabsorption, and tubular secretion. So we've done all 3 parts. We talked about how we concentrate our urine down, Okay, we talked about the hormones that are involved. We can use urine to look for different signs of disease. A lot of times, you know, when you go to the doctor, you give a urine specimen, and they look at that urine more than just putting the little stick in like we did in lab. They don't just look at pH and proteins and glucose or ketones. They also look at things like the color of your urine. And they can also examine your urine to look for renal function. How well are your kidneys working? Do you have any nitrogenous waste in your urine? If so, that shouldn't be happening. So they can look for things like that. They can assess to see if you have white blood cells or red blood cells in your urine. So one thing I told you they look at is the color of your urine, the transparency of it. Your urine should be clear. So it should not be like cloudy. It should be nice and clear. If it's cloudy, it can indicate that you have a urinary tract infection. Most of the time, though, a urinary tract infection is going to come with other symptoms. Urinary tract infections, the symptoms a lot of times are you feel like you got to go all the time, right? It's like you pee, you stand up, and you're like, oh, I'm not done maybe. Maybe I have to go some more. So you just constantly feel that urge to go to the bathroom. Urine should be sort of a yellow color. Usually we want it to be as clear as possible, so as pale yellow as possible. But it can be a deeper yellow depending on how concentrated your urine is, which reflects how hydrated you are. This comes from, the yellow color comes from urochrome. Urochrome is that pigment from hemoglobin breakdown. So again, the more concentrated your urine is, the more we're going to see that urochrome, so the more yellow your urine's going to be. An abnormal urine color would be like pink or brown, or I don't know what smoky means. Shouldn't be smoking, but sort of a brown color. If your urine is brown, what does that mean? No. Sometimes it could be blood. Usually it's more of a pink color if you've got red blood cells in there. Brown means you are severely dehydrated, right? If your urine is brown, that is that your urine is, you are incredibly dehydrated. There are some other things, though, that can change the color of your urine. Maybe foods that you eat might change the color of your urine. They can definitely change the smell of your urine. Drugs. Can you think of any drugs that change the color of your urine?
It's one that change it blue.
What?
It's one that can change it blue.
Oh, I don't know that one.
And it's one that can change it orange.
Yes. So, sorry? Yes, there is one form of tuberculosis medicine that I think will change it red. But I don't know what changes it blue.
What's that UCI medicine?
Yeah, that AZO stuff, that'll change it orange. So yeah, there's some medicines that will change the color of your urine. The odor of your urine, this is from your book. I don't know that I would call urine aromatic, but it definitely has a distinct smell, right? You can tell what urine smells like. Obviously, if urine sits and it gets old, it develops sort of an ammonia smell to it, and this is from bacteria. The bacteria feed on it, they metabolize it, and they give off that ammonia odor. Again, you know, it can be altered. The smell of your urine can change based on the food you're eating. Can you think of any food that makes your urine smell different? Yes, asparagus. That's, everyone always says that one. Coffee, like I'll notice if I drink coffee, my husband jokes, this is really gross, I shouldn't tell you this, but my husband drinks a lot of coffee, and sometimes like he'll drink so much that he'll be like, well, I could just put that right back in the pot because it smells just like coffee, which is really gross. But coffee will change the smell of it. There are some vegetables that will change the smell. pH of your urine can be very, very wide. Normal pH is slightly acidic, so pH of about 6. That would be if you have an acidic diet. So if you're eating a lot of red meats, a lot of proteins, a lot of whole wheat, your pH is going to be more acidic. It'll be lower. If you have a more alkaline diet, a more basic diet, like you're eating a lot of vegetables, or if you have a stomach bug and you've gone through prolonged vomiting or diarrhea, a lot of times urinary tract infections, these can raise the pH of your urine, okay? The vegetables will raise the pH of your urine. It makes sense if you think about vomiting. If you are vomiting, you are reducing the amount of acid in your body because you're vomiting up stomach acid. When you reduce the amount of acid, that means your pH becomes more basic. So your urine pH will change. You don't really have to worry about specific gravity. This is basically just the ratio of mass of urine to mass of distilled water. Distilled water is water that has nothing in it, right? Well, urine has water in it, but it also has stuff in it. So the specific gravity is a little more than 1 because, it has more than what distilled water would have in it. Again, it's going to kind of depend on the solute concentration of your urine as to what the specific gravity is. Urine's mostly water. It's 95% water and 5% solutes. Most of the waste that's in our urine is nitrogenous waste. Again, this is coming from your bloodstream. It's coming from metabolic reactions. It's waste we don't need. So urea is actually formed from the breakdown of amino acids. As you break down amino acids, you form this urea. This is one of the biggest components of urine. Uric acid, this comes from the breakdown of nucleic acids. And creatinine, this comes from creatine phosphate. So these are all normal wastes in our urine. Other normal solutes I have listed up here, things like sodium and potassium, magnesium. Abnormally high levels of anything that we've talked about, or any abnormal components like whole blood proteins or red blood cells or white blood cells or bile pigments might indicate a problem. So again, this is why when you go to the doctor, they always take a urine specimen. It's usually the first thing they make you do. You have to go pee in a cup. Now, once that urine is formed, remember it moves through the minor calyx, the major calyx, the renal pelvis, then it's going to drain from the kidneys through the ureters. The ureters are going to dump into the base of the bladder, kind of on the back side of the bladder. And as the bladder fills up, the pressure in the bladder is going to start to increase. Think of a water balloon. And it's going to cause where the ureters dump into the bladder, it's going to cause those ends to close, because the last thing you want when your bladder's really full is urine to back up in your kidneys. That would shut your kidneys down. So as your bladder fills up, those ureters and the openings where they dump into the bladder shut and close to prevent backflow. Now your ureters are teeny, teeny, tiny tubes. And they still have 3 layers to them. They have mucosa, that's the inside part. It's made of a transitional epithelium. Remember, transitional epithelium, we looked at this one or talked about it in AP1. This one changes based on the distension of the organ. So transitional epithelium is nice and thick when you have no urine in the bladder and ureters. But as they fill up, it gets thinner. Think of a balloon, right? If you were to just pick up like a balloon that hasn't been blown up yet, if you're looking for one that's like a dark blue, you might pick it up, and as you blow it up and the latex thins out, you might notice, oh, this is purple, or this is a different color, this is black. But they all look the same when it's deflated and thick, right? So as it fills up, that epithelium thins out, gets thinner. The next layer is the muscularis layer. It's made of smooth muscle. This helps to contract and propel the urine down to the bladder. It also helps the bladder contract. And then the outermost layer is the adventitia. This is fibrous connective tissue. This is looking at a cross-section of the ureters. So you can actually see in white, all that in white, that's the lumen. So that's what the urine can pass through. Right? And you can see the layers, right? So you can see the mucosal layer here, that transitional epithelium. So those ureters are really little. It is possible for people to develop something called a kidney stone. Has anybody had kidney stones in here? No? You have? What's it feel like?
Like having a muscle cramp while being poked with a hot iron.
Hell, it feels like hell. Yeah, where would the pain be?
Right lower side mostly.
Yeah, so back, right? That's what people don't realize. When you have kidney stones, where the pain is, typically we call it the flank. It's actually in the back. Because think about where your kidneys are found. Think about the rat. When you try to find the kidney in the rat, you got to pick up all the organs, and you find the kidney way on the back of the abdominal pelvic cavity. And so they're on the back. So when you have a kidney stone, you feel pain kind of, we call it the flank region in here, right? And it starts as a pain where, at least mine start as like a, can't get comfortable. Like it almost feels like there's something wrong with my muscles. And I kind of move, and no matter how I move, it just doesn't feel right. And then usually it becomes sort of a much more intense pain. I can actually feel it when I have them. I can almost feel the pain sort of migrating down my back as the stone moves down my ureter. So we call kidney stones renal calculi. And we have different kinds of kidney stones. They can be made of calcium, they can be made of magnesium, or they can be made of uric acid. If you have a kidney stone that's really large, typically where they form is they're going to form in the kidneys and the renal pelvis. And then from there, they eventually funnel into the ureters. You will not feel them in the kidneys. You only feel them when they start moving into your ureters. Because again, the ureters are teeny tiny. And so you'll feel them as they start moving in. You'll have a lot of pressure and pain. And the reason people get kidney stones could be they might have bacterial infections, so chronic infections in the kidneys. They might not be going to the bathroom as often as they should. Maybe they're holding their urine too long. It could be you have excess calcium in your blood. Normally, if somebody has a calcium kidney stone, this is a stone made mostly of calcium, there are medications they can take, and the medicine causes you to put the extra calcium, instead of urinating it out, put it in your bone. That's where we need it, right? So there are medicines for that. And then also the pH of your urine. If your pH is too basic, maybe you eat a lot of vegetables, a really basic pH can cause the formation of kidney stones. So lowering the pH helps. Eating more red meat. This is going to sound weird, but drinking a really dark beer can actually help prevent kidney stones, like a Guinness. I don't like Guinness. Guinness is like drinking motor oil, but it's supposed to help lower your blood pH and help to remove kidney stones. The treatment for kidney stones, it kind of depends. Sometimes it's basically just like wait it out, let the pain, just let it get into your bladder. There's not much they can do for you. If the kidney stone is large enough and it gets stuck and it won't move, problem is your kidneys still work, they still make urine, the urine can't drain. So the kidney will start to swell, we call that hydronephrosis. That is super painful. So if that happens, they've got to get that stone out of your ureter. So they may do something called ultrasound lithotripsy. It's where they don't have to cut you, they put these machines on, send ultrasonic waves in that break the stone up into smaller pieces so that you can pass it. So that one's pretty non-invasive. They also might end up having to put in a shunt to open up the ureter a little bit to help that stone pass. Once urine makes it into your bladder is basically just a temporary storage tank. It's a muscular sac, stores the urine. We find it on the pelvic floor. In males, the prostate gland sits right under the bladder. So it's basically where the bladder and the urethra come together. The prostate gland circles the base of the bladder around the urethra. In females, our bladder sits in front of the vagina and the uterus. So, like, this is a good model. It's terrible. It's terrible. So this model shows it really well. So obviously this is a female. So here is the vagina, this little tube right here. Y'all can see that little tube, that's the vagina. Okay. Obviously the uterus has a baby in it. And then this thing right here, that's the bladder. Okay, so it sits in front of the vagina and the uterus. This is why when you're pregnant, you see where that baby's sitting? Like right on top of that bladder. So this is why when you're pregnant, you feel like you gotta go to the bathroom every 5 minutes. Because the baby sits right on that bladder. Now there's an area, I'll show you a picture, called the trigon. So this is a female bladder. You can tell it's a female bladder because the urethra, that tube right there that drains the bladder, is very short. You can see the ureters here. These are going behind the bladder and they enter into the bladder here, kind of at the base towards the back. And then right here, this is the opening for the urethra. So the trigon is this sort of triangle-shaped region where you have the opening of the ureters and the opening of the urethra. Now the trigon is also a place where infections tend to persist. Okay, so if you get a bladder infection, it's typically going to be right here, especially in females. You know, I mentioned to you females, you know, we have this short urethra. So wiping the wrong way or intercourse can very easily push bacteria up into the bladder because this is so short. And the bacteria really just grow rampant right here in this trigon. If you get a bladder infection, it makes you feel like you got to pee all the time. If you don't get that treated, it can very easily, the bacteria can spread up through those ureters and into the kidneys, and then you have a bigger problem because you develop a kidney infection. Now your bladder, when it's empty, it has lots of folds in it. These are called rugae. And when it's full, the rugae go away. A full bladder is about 12 centimeters long. It can hold about 500 mils of urine, but it can hold twice that if it needs to. So it can hold a lot of urine. However, if your bladder becomes over-distended, if you cannot void your bladder, it can burst. So that is possible. I have a urologist, and the nurse was telling me that whenever I go to the urologist, one of the very first things, I got to pee in a cup, and they'll tell me, make sure you get rid of everything. And then I have to come back in, and they do an ultrasound to make sure that I don't have any urine left in my bladder, to make sure I'm voiding everything out when I go to the bathroom. And she said that she had just had a man come in who went to the bathroom, said he got rid of everything, and she did an ultrasound, and she said his bladder was still like 1,000 mil. It was so full. So she said they ended up having to put in a catheter and drain it, and she said they got like 900 mils of urine out of his bladder. So he had just stored, like he just thought he was going, but he wasn't. And so the danger of that is that it can rupture. So this is like a dye test. They can give you some dye that'll light up, and they can look at, as your kidneys take up that dye, they can look at a lot of structures. They can look at the minor calyces and the major calyces. They can look at the renal pelvis. They can see the ureters. They can see the bladder. So they can see all the urinary structures just by giving you this dye. Now again, the urethra is what drains the bladder. This is mostly a pseudostratified columnar epithelium, except near the bladder it's a transitional epithelium, so it can stretch. And at the very opening of the urethra, it's stratified. Reason is, remember, stratified is thick, and it's there for protection. You're going to find this in all the openings of your body, right? Your mouth, lining your mouth is stratified. The upper respiratory tract is stratified. It's just there for protection. They do have some sphincters around the urethra. You have an internal and an external sphincter. The internal is on the inside, and this one is involuntary. So you have no control over the internal sphincter. This one will contract. When it contracts, it opens. And this is a reflex. This is going to happen as soon as the bladder is full. Very similar to the anal sphincter muscles. But we have an external urethral sphincter. This one is voluntary. It's made of skeletal muscle. And this one you have conscious control over. Okay, so if we look at a picture, you can see the external sphincter here and here. That's the one you have conscious control over, so you can keep that urethra closed until you are ready to go to the bathroom. Again, it takes us a while to learn to control that muscle, and so this is why you got to diaper a baby, right? Until they're a little bit older and they can learn, oh, this is what it feels like when I have to go, and this is how I can hold it. I've already mentioned that the female urethra is pretty short. It's, 1 or 2 inches. It is tightly bound to the anterior vaginal wall. It is not the same as the vagina. So within the vagina, sort of tightly bound to the front, the anterior wall of the vagina, you have another opening for the urethra. Okay? You do not urinate out of the vagina. I get a lot of people that think that. You have 2 separate openings right there. The male urethra is a little special because it's not just carrying urine, it's also carrying semen. And the male urethra is much longer than the female urethra, so we actually have different names for the male urethra depending on where we're looking. So the prostatic urethra is the part of the urethra that is moving through the prostate. So remember, you have a bladder, and then you have the urethra draining it. And I told you that the prostate sits right under the bladder and kind of circles the urethra at the very top. So the prostatic urethra kind of flows through where that prostate is. Then you have the intermediate part of the urethra. This is going to pass through the diaphragm, those urogenital diaphragm muscles, and into the beginning of the penis. And then the spongy urethra. And this one is basically going to pass through the genitalia, pass through the penis. One thing I want to mention, you know, men, a lot of times they might have prostate issues. They might have an enlarged prostate as they age. And if we think about the anatomy, I'll show you a picture. So here's the bladder, just write a B right here. And all of that is the urethra. So you can see what it's passing through. And you can see in this area here, this is the prostate. So you can see that the very beginning of that urethra passes through the prostate gland. That's our prostatic urethra. So if the prostate gland is swollen, if it's enlarged, then it's actually going to start squeezing on the urethra. And it makes it really difficult for men to void their bladder if they have an enlarged prostate. If you've ever seen commercials, like there's a commercial for, I guess it's medicine, prostate medicine, and it's like you feel like you have to go all the time. It's talking about men always feeling like they have to go to the bathroom. And that's why they might have that feeling. You can see the intermediate part of the urethra right here. You can see it's passing through the diaphragm. You have some diaphragm muscles right here. Ladies, we also have these diaphragm muscles. Let me go back to where ours is. Here. These are our urogenital diaphragm muscles here. If you've ever heard of Kegel exercises, Kegels, I don't know, I call them Kegels. I don't know. It's the ones where you can work your Kegels if you go to the bathroom, if you're peeing, and then try to stop it right in the middle. And then pee, and then stop it. And then pee, and then stop it. You should do that all the time. It works your Kegels, and it helps to increase your muscle control so that when you have babies, babies can really, they just tear it all up down there. So when you have babies, sometimes, like a friend of mine, she posted a video, she went to like Sky Zone, she was jumping on a trampoline, and I'm like, woo girl, I just peed watching you do that. I cannot jump on a trampoline because I will piddle all over myself. I'm sorry. You're going to find out. You'll lose some bladder control when you have babies, especially big babies. So doing those Kegels help to tighten that up so that you can maintain some bladder control. So that's the way you can do that if you've never done Kegels before. Pee, stop it. Pee, stop it. The term for urinating, we call this Mctrition. And there's three things that have to happen when you urinate or void your bladder. One is you have to contract the muscle lining with your autonomic nervous system. Remember, autonomic means involuntary. So this is when the bladder is full, it automatically triggers that. The internal sphincter is going to open. Again, that's autonomic nervous system. This is smooth muscle. You have no control over this. So these are both involuntary. The external sphincter is controlled by the somatic nervous system. Remember, that's the voluntary part of your nervous system. It controls skeletal muscle. And that external sphincter is skeletal muscle. You have conscious control over it. Again, it takes a while for you to learn the control over that external sphincter. This is why urination in an infant is reflexive. Just as soon as the bladder is full, they go. As we age, incontinence is pretty common, and it's from the weakened pelvic floor muscles, that diaphragm, urogenital diaphragm. Stress incontinence can happen. This is when you increase the intra-abdominal pressure. So if you laugh, cough, sneeze, any of those things, you're increasing the pressure here, and sometimes you might piddle a little bit when that happens. Okay. Overflow incontinence, this is common if the bladder fills up, it's really full, it might come out a little bit. Urinary retention is just the term we give when we cannot void the bladder. We cannot expel urine. This is super common after general anesthesia. If you've ever had general anesthesia or any kind of surgery, a lot of times when you wake up, you'll have a catheter in if the procedure was long enough. If not, if you don't have a catheter in, as soon as you wake up, they're going to say, we need you to eat and drink, and we need you to go pee. And they will not let you go home until you void your bladder, especially if it's just an outpatient procedure. And if you cannot void your bladder, they're going to put a catheter in you because they don't want the bladder to get too full. In terms of the development of the kidneys, you actually have 3 sets of kidneys that form. You have something called the pronephros. These degenerate over time. The mesonephros and the metanephros. It's the metanephros that develop into the adult kidneys and descend. In a fetus, the kidneys, these metanephros, they'll start filtering the blood and they start making urine by the 3rd month. Okay? So you can see here, this is just sort of a progression from week 5 all the way down to week 8. And you can see here those metanephros, and you can see that they sort of enlarge and they look much more like adult kidneys by week 8. You can also see things like the ureters. You can also see the urinary bladder has formed. So all this forms very early. We're going to talk about, in chapter 28, we'll talk about development, fetal development. Everything, all organs, everything is formed within the first, usually about 8 weeks, 8 to 10 weeks. And then after that, the whole rest of the gestation period is just there to beef everything up, for the baby to get bigger, and for all those organs to basically finish growing and maturing. Last things I want to talk about are just some imbalances. These are some abnormal congenital conditions. So babies are born sometimes with these conditions. One of them is called a horseshoe kidney. This is when the kidneys look like this, kind of a horseshoe shape. Usually the kidneys are functional, and you would never know that you have this unless you had any kind of issues. Maybe you have a kidney stone and they do a scan and they find this. But otherwise, you would never even know that you have this. Usually it's asymptomatic. Hypospadias. This is when the opening of the urethra is on the ventral surface of the penis. So you can see it can be found in different places. So here you can see it's on the ventral surface. It's still on the head of the penis, but it's just not right at the end. Here you can see it's more on the shaft of the penis. And here you can see, I can't circle it, over here. It is basically between the penis and the scrotum. Obviously, this is going to cause a problem not just with urinating, in terms of making sure that you get it in the right spot. All little boys have that problem, whether they have hypospadias or not. They can't get it in the hole. But this is going to cause fertility issues. Obviously, we need the opening of the urethra because it's carrying not just urine, but also semen. We need it to be at the very end of the head of the penis, so that when semen is released, it's released right at the cervix. Okay, you can imagine if it's released down here, it's probably not even going into the vagina. Okay. Usually this will get corrected surgically at around 12 months. So they basically just recreate a tube. They'll open it here at the end and they close this up down here. Another disorder is something called polycystic kidney disease. That word poly means many. Cystic is just cysts. So you have many fluid-filled cysts all over the kidneys. The problem is these cysts interfere with the function of the kidneys. So you can't filter your blood and get rid of waste. They don't know what causes this, but the treatment for this, if the kidneys aren't functioning, that patient would have to be on dialysis until they can get a kidney transplant. In terms of development, it is really common for infants to urinate a lot. That is one thing that, you know, I feel like I wasn't prepared when I had I was prepared, but I wasn't prepared. You just don't know what to expect when you have a baby. And, you know, one thing, like I bought all these size 1 diapers because I'm like, what's size 1? Like, this is where we start, is at 1. I have no idea that they made newborn diapers. I feel really stupid. So my child, teeny tiny, he's still teeny tiny. And so I have all these size 1 diapers, and we get home and I'm like, yeah, honey, you gotta go buy diapers. And I feel like we just rolled through diapers like crazy. Funny story, when I was little, so my dad used to work at Procter & Gamble. He was an engineer. Procter & Gamble makes Pampers. And so when I was growing up, I was born in, we'll say the 80s. We'll leave it at that. I was born in the 80s. And at the time, my dad we worked downtown at Procter & Gamble. He could go to the Pampers plant, and any misfolded diapers would go into an offshoot in a big bin. And anyone that worked at Procter & Gamble could just go get diapers for free. They could get any of the misfolds for free. And so I and my brother both, we were both allergic to the dyes that they put in those diapers. At the time, they didn't make sensitive diapers and all that stuff. They all had dyes and perfumes in them. And so my dad could get diapers for free. And my mom had to do cloth diapers. She had to have like a service come and she had to like rinse them in the toilet. Oh, terrible. But babies go to the bathroom all the time. So I cannot imagine if I did not have disposable diapers, I had to be using cloth diapers. Whew, that's rough. Incontinence is really normal in infants. They don't gain control of that sphincter until they're a little bit older. It kind of develops with the nervous system. E. coli, again, this is coming from, usually it's coming from the anus. This accounts for about 80% of all urinary tract infections. If your child has strep is a really nasty bacteria. It can cause strep throat. It can also cause heart problems, and it can affect the kidneys. So it is really important that if you have a strep infection that you get it treated. Sexually transmitted diseases, STDs, we will talk about these in the next chapter. These can also inflame the urinary tract, so they can cause problems as well, along with problems with fertility. Most elderly people have problems with their kidneys. Their kidneys histologically do not look the same as they did when they were younger. The kidneys get smaller, the nephrons are smaller, so they're not as efficient as they used to be. And the bladder shrinks, you lose bladder tone, muscle tone in the bladder, so incontinence is really common as we age. Okay?